Yeah, good evening, everybody. Good evening, friends. I'm Dr. Subhal Dixit. I'm a consultant and director of critical care and the past president of the ICCM. I've got immense pleasure to moderate this today's session, an excellent session on the management perspectives of ARDS. And we have got excellent plan today. There'll be two talks today, and first talk will be by Dr. Arnab, Bera, who will be talking about and giving a perspective about ARDS. And this will be followed by a talk by Dr. Neel Thakkar, who will be introducing the various aspects about the ventilatory management of ARDS. And this will be followed by a panel discussion with all the four eminent panelists, where Dr. Arnab, Dr. Neel, Dr. Vikas, and Dr. Nilanjan all will be, along with Dr. Viswesvaran, will be a panelist. I'll be very happy to moderate. On behalf of the CCI, I welcome everybody for today's session. I welcome all the audience for taking out time for today's session. And thanks CCI for hosting this excellent webinar and the most important webinar on a very important topic which is not yet been covered. So with this short introduction, I would like to invite Dr. Arnab Bera and request him to talk on the perspective of ARDS, what he feels. Over to you, Arnab.
Hi, welcome and good evening, everybody. So today the webinar on ARDS, it will be on the recent advances and the changes. Okay. So I am just I will just give a brief talk of ARDS regarding its overview, the recent change in definitions, and something about the pathophysiology. And the rest part, the management part, the ventilatory management will be taken care of by Dr. Neel after me. So to start with, so acute respiratory distress syndrome is a diffuse progressive inflammatory lung disease that was first reported in 1967 by Osberg and his colleagues in a cohort of 12 surgical patients. So what they noted, they exhibit acute onset tachypnea, hypoxemia, and loss of compliance. So this was the first thing. And then the first most important definition actually came from the ACC meeting in 1994. So that they defined the ARDS on the basis of these four parameters actually: timing of onset, oxygenation, absence of cardiac failure, and the chest radiographic findings. So these are definition actually, they divided in two broad categories. You can see here, that is acute lung injury and ARDS. Both are acute onset bilateral infiltrates, and both have the pulmonary wedge pressure of less than 80. The difference is the ALI is less than equal to 300 millimeter of mercury, and ARDS is less than 200, regardless of the PEEP. They have not mentioned any PEEP in this definition. Okay, so this is the ACC criticism. So they have not defined any time frame. They are just told acute onset, but the time frame is not defined. The category of PAF ratio 200 to 300 are some confusing. What is ALI? What is ARDS? Okay, but in Berlin definition that is at risk, there is three mutually exclusive subgroups of ARDS. Regarding the oxygenation part, there was no effect of PEEP that was mentioned in ACC. So this is one of the limitations that is also addressed in the Berlin definition. And in chest radiograph, bilateral opacities or infiltrate, that can be anything. Okay, so that is also addressed in the Berlin definition. So we have to clearly define the radiographic opacities. Okay, and the pulmonary artery wedge pressure. The problem is that the high pulmonary artery wedge pressure and ARDS may coexist. Okay, so if you see this slide, so there was this in this study, 48 patients were initially diagnosed with ACC criteria with ARDS with a PEEP of 0. But after 6 hours of PEEP, the PF ratio goes more than 200 in 52% of patients, and after 24 hours, it gone up to 62% of patients. So is it a true ARDS? Another thing is that according to the mean arterial wedge pressure, pulmonary wedge pressure. So 82% of the ARDS patient has at least one measurement of more than 18 in some occasions. So these two are important fallacies of this ACC criteria. So there comes the Berlin definition of ARDS. Okay, so it's a very clear-cut definition. So within 1 week of a clinical insult, bilateral opacities that not fully explained by effusion, lobar or lung collapse or nodules, origin of edema, that is respiratory failure not fully explained by cardiac failure or fluid overload, that needs an objective assessment of echocardiography to exclude hydrostatic edema if no risk factor is present. And they define three mutually exclusive categories of mild, moderate, and severe. That is a PF ratio of 200 to 300, 100 to 200, and less than 100, with a PEEP of more than 5. In cases of mild, they also mention CPAP of more than equal to 5 for patients who are on non-invasive ventilation. But Berlin do have a problems. So, if you go by the histopathological definition of ARDS, so there must be diffuse alveolar damage in the autopsy. That is a reference standard. But if you go through this study, you will see that in cases of mild, moderate, and severe cases, this criteria was met in only 12, 14, and 58% of patients. Okay. So in cases of severe category, more diffuse alveolar damage is found, but that is also up to 58%, not in all cases. And more the duration, if the ARDS duration is more than 72 hours, the diffuse alveolar damage is found in almost 69% of patients, but not 100%. So these, in cases of mild ARDS, you can see the less than 20% is diffuse alveolar damage. In cases of severe, it is almost around 60%. And this is less than 72 hours and more than 72 hours. Up more than 72 hours, almost 60% of diffuse alveolar damage is seen. So another term which is come in Pulmonary 2008 is a pseudo-ARDS. That is also a failure of the Berlin definition. So pseudo-ARDS has three patterns. Volume pattern. So pseudo-ARDS volume pattern means the patient initially come with a non-cardiogenic pulmonary edema, maybe due to pneumonia or pancreatitis or whatever. But subsequently, iatrogenic volume overload is superimposed over the injury. And that is the major driver of deterioration. So primary lung injury increases the permeability of endothelium, rendering the lung more vulnerable to volume overload. But with diuresis, the patient improves much faster than a true ARDS patient. So this is a volume pattern. Next is the effusion pattern. If you see in this CT scan, so there is bilateral moderate effusion is there, but the lung parenchyma is not bad. There is atelectasis. That's why the hypoxemia is because of this hunting of the deoxygenated blood through this atelectatic tissue. So if we drainage or if we give diuretic, that may improve. And this is the collapse pattern. So prior to intubation, you have seen the patient was requiring 100% oxygen with a high flow nasal cannula. But after intubation, you see the change in the X-ray. The X-ray looks almost clear and the FiO2 requirement is decreased to 30%. So these are collapse or atelectasis pattern. So the Proseba definition of ARDS, that is a very much improvement over the Berlin. They actually take ARDS with a PF ratio of less than 150. The intubated patient are less than 36 hours, MAP of more than 65, no inhaled pulmonary vasodilation, no intracranial. So this was their clinical inclusion criteria. But if you see this slide, how they approach to ARDS. So patient intubated who appears to have moderate severe ARDS as per Berlin criteria, okay, that's good. Then they optimize the ventilator for 12 to 24 hours. They attempt recruitment, trial of APRV, they diuresis the patient if the signs of volume overload, they drainage the effusion if there is potentially significant effusion. If then the PF ratio improves over 150, so that patient does not meet criteria for paralysis and proning. But if the patient, even after that, it remains less than 150, then they only take the patient for Proseba trial. So if after optimization of ventilation, PF ratio improves over 150. This is not fully a severe ARDS. So they excluded the patient from the trial. But less than 150, that means it probably confirmed ARDS and the trial, they included this in trial. So in gist, the problems with Berlin, you can see broad definition, not used in this trial. Less than 150 possible ARDS, but rapid improvement, it goes more than 150, possibly pseudo ARDS. Proseba most clinically meaningful in this situation. Non-diffuse alveolar damage ARDS. So they are very less poorly electron sensitive, and sensitivity is around 89%, but specificity is very poor, around 60%. Berlin definition positive, but diffuse alveolar damage is present in only 58% of cases, and there is poor mortality prediction. So Keeglin made a modification of Berlin, but basically this modification is basically for mainly for the resource limited settings. Actually, they take PA in SpO2 instead of PaO2, and the ratio is less than 315. They also took no PEEP as per the ACC criteria, and they also took chest radiography and ultrasonography in cases of chest imaging, not CT, because CT is not readily available everywhere. So in resource limited setting, they actually do this modification. And this is the proposed new global definition for ARDS. It is not acceptable till now, but this is on process. So what are the inclusions in this? This is not a replacement of Berlin definition, rather than this is an addition to Berlin definition. So intubation not required, because in cases of mild ARDS, we can use NIV, we can use HFNO. So the HFNO more than 30 liter per minute, that is included in this definition. And they also include this SpO2 FiO2 ratio of less than 315 with a SpO2 of less than 97 also in this definition. But we need the whole study to see what is actually going on. Okay. So a little bit about the epidemiology of the ARDS. So ARDS mainly represented almost 10.4% of ICU admission, and 23.4% of patients actually required mechanical ventilation in this study. And mortality is around 20% in mild, 30% moderate, and around 40% in severe. So what is the prognosis of ARDS? So 30 to 50% patients have cognitive dysfunction, and this is almost proportional to severity of hypoxia. 30 to 60% have psychiatric disturbance like depression, anxiety, but that is not in proportion with the severity of illness. There is some physical limitation in terms of 6-minute walk distance. 38% of patients almost have weakness at discharge. In terms of PF2, 80% of patients have DLCO limitation at discharge. 20% of patients have obstruction and restriction pattern in cases of ARDS following discharge. So what are the causes? You all know this, I think. I'm not going into details of it, but a little bit about the direct injuries, about pneumonia, aspiration, contusion, inhalation injury, drowning, and there's some indirect injury like sepsis, non-thoracic trauma, pancreatitis, burn. So a little bit about pathogenesis and sequence of ARDS. So ARDS, as I earlier told you, is characterized by diffuse alveolar damage, hyaline membrane formation, diffuse fibroblast proliferation, and fibrosis. So there are three main pathological phases. First one is exudative, 0 to 6 days, better recruitable lung. Proliferative phase, proliferation of type 2 cells and fibroblasts, 7 to 14 days. And fibrotic phase, more than 14 days. Either there is resolution phase or fibrosis. So this is a picture of exudative phase. You can see the alveoli is filled up with fluid and there is leakage of this fluid. And in cases of proliferative phase, there is the endothelial cell and proliferation of the fibroblast and leading to provisional matrix form. So there's at the early stage. And there's also proliferation of type 2 cells. And in cases of fibrotic phase, there is widespread extensive deposition of extracellular matrix leading to intestation and intra-alveolar fibrosis. So these are the phases of ARDS. So what is the consequence of this? So refractory hypoxemia and shunt first. So flooding of the alveolar space with fluid, protein exudate, alveolar collapse due to absence of surfactant, non-cardiogenic pulmonary edema due to leaky capillaries, inflammatory edema causing widening of alveolar septum, causing decreased diffusion. So all lead to mismatched ventilation perfusion underneath this collapsed alveoli. And there is also decreased compliance due to alveolar flooding on collapse. And there is also pulmonary hypertension and right heart failure, you can see from the ARDS. So the causes are mediator-induced vasoconstriction, hypoxic pulmonary vasoconstriction, vascular compression by edema fluid or fibrosis, vascular wall remodeling, thromboembolism, reduced lung volume. That all can lead to pulmonary hypertension and right heart failure. So these are also an important part of ARDS when the hypoxia is not corrected. So we have to see for the right heart function. So I'm not going into details of them in the management part. The major change or recent advance, you can see from lung protective ventilatory strategy, we are going into lung and diaphragm protective ventilatory strategy because loss of the patient due to high PEEP rather suffered from myotrauma or diaphragmatic weakness that may lead to extubation failure in many of patients. So this is one important part. I think that will be discussed in the panel discussion too. And if you a skeletal of the management or management of ARDS, when the patient is confirmed ARDS, we ventilate them. In case of moderate severe, we ventilate the patient with a 6 ml per kg of predicted body weight with a target of plateau pressure of less than 30 and PEEP of more than 5. Once the PF ratio less than 150, though, there is a thing for prone when there is indication comes of prone positioning, prone ventilation, and when it comes below less than 80, though, there is a role of venous ECMO. So these in gist the basic things of regarding the ARDS and regarding the definition part. And from now on, the next part, the management and the ventilation part will be taken care by Dr. Neel. So I hand over to Dr. Neel for the next session. Thank you.
A very good evening to all the members of Chest Council of India who have joined in today's webinar. Thank you, organizing committee of the webinars, Chest Council of India, Dr. Inish Krishna sir, Dr. Vijay Kumar sir, for kind invitation for this panel discussion. I will be talking about ventilatory management of ARDS with regards to its practical implications and recent advances. The scope of today's discussion will include these are the topics which I'll be including: the important pressures, practice implications of the ATS definition, ventilation in ARDS, plateau pressures, and some important trials. So before we start off any discussion, ventilation, we need to know about the various pressures in the ARDS. So peak inspiratory pressure, plateau pressure, driving pressure, and positive end expiratory pressure. As we can make out in the figure, the inspiratory maximum pressure in the smaller airways, which is measured just after airflow has ceased, is the plateau pressure. And it is measured during the inspiratory pause in the mechanical ventilator. Positive end expiratory pressure is the one which remains at the end of exhalation and is normally greater than the atmospheric pressure. If we can make out in the graph here, peak inspiration, then the plateau. The difference between the plateau and PEEP is the driving pressure, and what keeps the alveoli open in exhalation, that is the PEEP. We have already discussed regarding the Berlin definition as well as the ATS modification of the Berlin definition, which has been proposed recently. Important with respect to management is in intubated patient, SpO2 FiO2 ratio is added. In non-intubation patients, HFNO or NIV with a minimum flow of 30 liters per minute, and to allow oximetry or ABG both to meet the oxygenation criteria. This is important to define ARDS and its practice implications later. Sonography is also a good modality for defining ARDS patients as per the proposed definition. Starting off with ventilatory management, baby lung is basically the portion of the lung which participates in the gas exchange in an ARDS lung is only 20 to 30%. The normal alveoli have been compressed, number one, because of the pathology itself. There is hypoxic pulmonary vasoconstriction, and also because of the volutrauma and barotrauma, which causes decrease in the ventilation. So clinical strategies this paper was published in the ICM in 2020. Strategies to minimize the trauma to the baby lung. We do not cause too much pressure, which causes overdistension, or too much volume, which causes volutrauma. And at the same time, we also do not prevent diaphragmatic problems. That diaphragmatic protective ventilation can also occur if excessive assist or low effort or drive is used. ARDS has a number of strategies which can be used in the ventilation. Number one is the non-invasive ventilation or the high flow nasal oxygen. Number two is the PEEP, then prone ventilation, neuromuscular blockade, and recruitment are the most important among these. This is a study which is published in the AJRCCM in 2017, which showed that NIV use was independently associated with increased ICU stay as well as poor outcomes. Ventilation so that is why we still prefer invasive ventilation more in ARDS patients. Ventilation approach is always low tidal volume. No, the higher the volume, it will cause more volume distension, volutrauma, and alveolar damage and more interstitial edema. The ARDS NET study, which is the landmark trial, which showed that low tidal volume was associated with improved survival. 6 ml per kg is the tidal volume we use. PaO2, FiO2 target of 55 to 80, saturation target of around 88 to 95% is the target. If brain injury is there, then 90% target is used, and incremental combinations of FiO2 and PEEP can be utilized. So first cardinal rule, 6 ml per kg of predicted body weight, not the body weight. Predicted body weight is calculated as per the height of the patient and not as per the actual weight. Lung protective ventilation, low tidal volume, and we have to prevent the collapse of the lung as well as recruit the lung properly. When there is increased shunt, increased hypoxia, recruitment becomes very important. Permissive hypercapnia is a good concept which is used in such patients. pH is more important than the PCO2. We allow some degree of hypoventilation so that we can achieve better ventilation with that. And permissive hypoxemia also, because we do not want problems with hyperoxia. So in ARDS also, we don't target 100%. Our target should be somewhere more than 88 to 90%. And we allow some alveoli to remain collapsed rather than causing overdistension. Problems with lung protective ventilation is auto-PEEP, sedation, and sometimes breath stacking can be there. So we have to deal with this when it happens in patient. We'll be discussing that in our panel discussion. Ventilatory strategies include the mode of ventilation, FiO2, and all these parameters which need to be seen. Pressure control or volume control, 2 modes of ventilation are routinely seen, but the ARDS NET study recommends the volume control mode compared to the pressure control mode. And around there are some advantages with volume cycle ventilation. It guarantees a tidal volume. Clinical familiarity is there. Disadvantages is airway pressures cannot be controlled. In pressure control ventilation, airway pressures can be controlled. Patient tolerance is better. However, tidal volume is not guaranteed as per the requirement. APRV is another mode which can be used, where we have to set a high and a low pressure both. And accordingly, there is airway pressure release ventilation with the normal tidal breathing. The second cardinal rule is that we have to keep a plateau pressure which is less than 30. And the incidence of ventilator-induced lung injury is reduced at these pressures, and recruitment of lung volumes with a function of PEEP, and it causes opening pressures which cause generation of the tidal volume. Plateau pressures are associated, higher plateau pressures are associated with mortality if the pressures are very high, and we can calculate plateau pressures with an inspiratory hold. And this is a graph which shows the static compliance. By the graphical method, we can see the upper inflection point and lower inflection point. That is how we set an ideal level of PEEP. Driving pressures, the new concept which I mentioned, that ventilator measures the plateau pressure. We subtract the PEEP to get the driving pressure. Normal target for the driving pressure is less than 20. And any increase in driving pressure by 7 centimeters of water is associated with a higher risk of death. To decide PEEP, most important are the gas exchanges, the compliance, the various pressure volume curves, and there are other advanced maneuvers by which we can decide an optimum PEEP. This is the PEEP FiO2 table as per the ARDS NET protocol, which we can use with increasing requirement. We can also see response in the ventilator, whether the patient is responding or not. Recruitable alveoli, more alveoli will accommodate. Same tidal volume, hence pressure can be has to be decreased in certain non-responders. As per the plateau pressure, we can take a call whether we can increase the PEEP further or not. Setting the PEEP with the loop is also possible, but now we have modern ventilators where the plateau pressure can be seen with an inspiratory hold directly in the ventilators. Recruitment maneuvers, various strategies are there to increase the transpulmonary pressure to open up the atelectatic alveoli. Pressure increment procedures lead to volume increment, and repeat recruitment maneuvers after position change, circuit break, or deterioration of mechanics or hypoxia is very important. It may not always work. Various strategies are there by which we can give incremental or stepwise PEEP to increase the recruitment maneuver, the chances that will help the patient. There is the staircase method also, where recruitment maneuver increases the oxygen saturation, and normally a drop in saturation indicates de-recruitment at that level of PEEP. So accordingly, we can have a stepwise decrease in the PEEP while watching the saturation. prone position works. This is one of the most important, the Proseva trial, which showed that when we make a patient prone, the heart rests on the sternum, abdomen contents don't hamper the ventilation, better secretion drainage, the ventilation perfusion is uniform, and it causes better oxygenation. So in prone position, we make the patient prone, which allows the posterior portion of the lung to come up and the anterior portion to go down. The effect on the heart and mediastinum is that the weight of the heart and mediastinum that in prone position is supported by the sternum and chest wall with no intervening lung, which allows better ventilation of the dorsal lung. Again, the Proseva trial showed that there was significant mortality benefit in the prone ventilation group, where 16% versus 32%. And with a PEEP, the use of PEEP in prone position, so pressure required to open the diseased alveoli is more than the normal alveoli. And if no PEEP is applied, these alveoli will wink open and close every tidal cycle. So shear stress causes decrease in the surfactant and disruption of epithelium. So this ventilation perfusion mismatch improves with the non-dependent lung in prone ventilation. There are some problems of skin breakdown, hemodynamic insufficiency, spinal fractures. These are cases where we may not be able to use prone ventilation, but we need to decide on case-to-case basis. The ideal duration is around 16 hours. High-frequency oscillatory ventilations are again other modalities for refractory hypoxemia which can be used. However, the Oscillate and Oscar trial both showed that it did not help much in cases compared to routine lung protective ventilation. ECMO Caesar trial showed reduced mortality in ECMO patients. However, to decide which are the best candidates, we have a Murray score, which we will be having a discussion in our panel discussion. There are various types of ECMO, the veno arterial and the veno venous ECMO. Again, we'll be having this discussion in our panel. There are certain modes where no survival advantage is there: inverse ratio ventilation, intratracheal installation of surfactant, use of pulmonary artery catheter. Again, in selective cases, this might help. However, major trials have not shown survival advantage. How to set up a ventilator? Most important, you calculate the predicted body weight, 50 plus the formulas which are used. You set the ventilator mode. In the ventilator settings, set 6 ml per kg of the predicted body weight. Set the initial rate to approximate the baseline minute ventilation, not to exceed 35. Adjust the tidal volume and rate to achieve a pH and plateau pressure. As we have discussed, a plateau pressure less than 30. And we have to adjust the respiratory rate and tidal volume to achieve this. Ideally, to achieve the plateau less than 30. pH goal is 7.30 to 7.45. We have to increase the respiratory rate or decrease the rate as per the patient's parameters. And in some cases, when the acidosis is very severe, we may have to even exceed the plateau pressure, but that depends on case-to-case basis. I ratio, normally we keep the duration of inspiration lesser than expiration, oxygenation goal target of 55 to 80, and saturation of 88 to 95%. In acute hypoxemia or ARDS, is an important slide where we set the PEEP and use the incremental PEEP FiO2 table to set incremental PEEP. Persistent hypoxia, then in such cases, again, we have to set the tidal volume. See for other causes, try to treat the infections which are there. Make sure supportive critical care is very good. And accordingly, as per the parameters, with good neuromuscular blockade, at least for 48 hours, we ensure good ventilation, prone ventilation in refractory cases. And again, supportive measures, including the IV fluids as well as adequate neuromuscular blockade where it is needed, and infection control, and looking for atypical infections where it is possible. Any thrombotic issues also is important when we treat ARDS patients. Traumas caused by the ventilator: barotrauma, volutrauma, atelectotrauma, biotrauma, and ergotrauma. These are the 4 traumas caused by the ventilator due to high plateau pressures, high volume, and sometimes because of the cytokine release, which causes biotrauma. Rescue strategies we've already discussed. Again, neuromuscular blockade agents are important. Prone is important, which have been proven strongly. Accuracy trial showed that 48 hours of neuromuscular blockade helped to improve outcomes. The Oscillate and Oscar trials I've already discussed did not show much benefit with high frequency ventilation. Caesar trial did show that ECMO treatment can benefit in selected cases of ARDS where the Murray score was more than 3 or whose pH was less than 7.2 despite conventional management. So take-home message from this session would be that lung protective ventilation should be the first approach. Stepwise increase in FiO2 and PEEP, low tidal volume of predicted body weight, plateau less than 30, prone position works, correct all ARDS and other medical factors, competent ICU care, sedation and fluid strategies, review at each step, pH is more important than PCO2, do not cause more harm in trying to reverse the hypoxemia. So with science, we can make out this gentleman here is John Heaven Emerson in 1931. He found the iron lung. And in 2023, this is the current smallest ventilator that is available to us. So we evolve with technology and as per the science. And thank you so much for your patient listening. We'll be proceeding to our panel discussion now with Dr. Subhal Dixit sir and the rest of the panelists. Thank you so much, CCI, for this opportunity and hope that we have some good, fruitful discussion now. Thank you.
Yeah, thank you, Neel. So I would like to start sharing the screen now. And so we'll be discussing about the panel discussion. I hope you can see my screen now. Can you see see?
Yes.
Yeah.
Yes.
So I'll be very happy to present a case, and we have got eminent panelists, Dr. Neel Thakkar, Dr. Vikas Sikri, Dr. Viswesvaran B, Dr. Arnab Bera, and Dr. Nilanjan Umesh, who will be a part of the panelists. So I'll just start a small discussion that to set the ball rolling here. We have a 26-year-old male without any comorbidities who presented to the ER with typical symptoms of fever, cough, body ache since 2 days. Examination, he was febrile, with a tachycardic 124 pulse. His MAP was 86. His saturation was about 88 on room air, but he was tachypnic with a RR of 32. He was put on 4 liters of oxygen with a face mask, and his saturation came up to 94 with that. Investigations were sent routine CBC, biochemical parameters, RT-PCR for COVID, and an X-ray chest was done. RT-PCR came up positive. Let's take RT-PCR in both ways as a COVID, as well as also take into consideration for discussion in this webinar, minus the RT-PCR, that this is a typical X-ray, sometimes also what we see for those patients. In this patient, his counts were 4,800. The hemoglobin was 13. Platelets were normal. He was put on remdesivir with prophylactic of LMWH, and dexamethasone 6 milligrams of intravenously was started. In due course, his tachypnea did worsen. His oxygen requirement went up to 10 liters. His ABG showed a PO2 of 86, pH of 7.4, PCO2 of 28. The lactates were 2.2. We got his markers, which were high. The ferritin was high. The inflammatory markers were high. The CRP was high. But most important for us, the CT scan, which shows a typical ARDS-like picture. The PF ratios were also less than 100, which were suggestive of an acute lung injury. So let's start off with the first discussion, although certain parts have already been covered up here. So I would like to have the ball rolling key. How will you really define the Berlin definition? Dr. Neel, can you just be short, because certain parts of the discussions were taken in the talk also by Dr. Arnab. So Neel, what do you think is the exact Berlin definition of ARDS?
So I think it's
Yeah.
Thank you. Sir, so as Berlin definition, we already discussed regarding the definition. Applying this to this particular case, this patient had an insult in the last 2 to 3 days, was
Right.
within 1 week, had bilateral opacities, definitely no bilateral pleural effusion we can make out, does not look like a definitive cardiogenic pulmonary edema. And based on, again, the oxygenation parameters, we have to see whether it falls into the mild, moderate, or severe. But again, if we stick only to the Berlin definition, in this case, we will be just, we do require a PEEP of minimum of 5,
Right.
except for a mild ARDS, but still there have been modifications with regard to the same, but that is why, again, these modifications are important, that in such cases where you have not applied positive pressure yet, still do fit into ARDS. That is why all these modifications took place later. So definitely this fits into, we don't have an echo report in this patient, but even ARDS can coexist with pulmonary edema. So still this fits into ARDS definition as per the Berlin definition.
Right. Dr. Vikas, can you just expand it further? What are the new definitions or the Kigali modifications which has come up? Can you just expand it? Dr. Vikas? Dr. Vikas, are you there? Okay, Neel, can you just take the same question and expand what is the further extension done into the Berlin definition?
So I'm audible now? Sorry to bother.
Yes.
Yeah. So Kigali, sorry for the interruption. The Kigali modification was taken up mainly for the resource limited settings. The origin is still from the Berlin definition. So 2 modifications has been done from the Berlin definition in the Kigali modification. First of all, the PA to FI2 ratio, sometimes the APG is not available. So they have changed from PA to FI2 ratio to SPO to FI2 ratio. And the cutoff, what they have recommended is less than 315, which is significant in these patients. Other thing is patients, the requirement of PEEP has been taken off by the definition, so that in the resource limit settings where the ventilator is not there or the patients are not using a ventilator, the PEEP criteria has been taken off. And third thing what we have then done is to quantify the infiltrates. They have introduced the ultrasound, which is increasingly being used these days in ICUs. Absolutely. But a lot of things, I think modification will also take some time, because there's lots of false positive rates of ARDS which has come up because of the Kigali. So some studies have shown that ultrasound is a very sensitive tool to pick up infiltrates and pulmonary edema as well. So a lot of false positive cases have been picked up by using this modification.
Yeah. That's a very nice way you put up that there is a minus to PEEP and the introduction of the ultrasound and also the pitfalls into this definition. So I completely agree with what you have said. Dr. Viswesvaran, we know that community acquired pneumonia is one of the aspects of further progression into ARDS. What do you think are the common causes of ARDS into the Indian population? This question has also been popped up into the chat box.
Yeah, so the most common that we see recent days is, as you said, it's most of viral community acquired pneumonias, which may be either in the form of an influenza or in the form of a COVID. But apart from that, we also see a lot of cases of aspiration, post-aspiration ARDS, which is very common, especially in patients who has got a CNS involvement. And even trauma can cause ARDS, lung contusions and trauma. That is another important, which contributes to a significant number of ARDS. And extrapulmonary, the most common we see is pancreatitis. So whenever a patient is having pancreatitis, we see a lot of patients with ARDS. And in ICU settings, sometimes blood transfusions can result in TRALI, which is also a most important cause. After ruling out all these causes, the other important causes that we see for ARDS are one, drowning. A few cases of drowning can present with ARDS. And in mass casualties, when you have an inhalational injury, it can present with ARDS. And certain drug toxicities rarely can present with ARDS. And even in HIV patients, PCP pneumonias can mimic ARDS. Yeah. And from a pulmonary point of view, there are certain things which mimics in ARDS, like diffuse alveolar hemorrhage. So until and unless we are cautious about looking into the hemoglobin or ET aspirate for serial aliquots of aspirate of ready aspirate, probably we may miss a diffuse alveolar hemorrhage, which will exactly mimic an ARDS. And especially with the recent onset of vaping and other things, until and unless we have very high suspicion, we may miss an acute eosinophilic pneumonia, which exactly mimics an ARDS but does not have any systemic symptoms related to ARDS. And as always, seasonal problems like dengue, leptospira, and even some sort of scrub typhus. These are the other common forms of ARDS which we generally see in our ICU.
Additionally, is falciparum malaria.
Yeah.
They are excellently well covered, Dr. Viswesvaran. So that's a very nice way. So all friends, remember, it's not just community-acquired pneumonia. Your spectrum of thought for the causing of ARDS has to be sometimes seasonal, and you must have a proper detailed history, which is very, very important. That's what exactly is the next question, which I'm going to ask Dr. Arnab to cover. Okay, how does he evaluate the patient of ARDS when he has it? And when does he say it's defined as ARDS? Arnab.
Yes, sir. So, as you told, sir, history is first most important, because with history, we can first differentiate between the two broader category. Is it a respiratory cause or is it a non-respiratory cause? And then the duration of the illness, that is also important. And once we go through the history, and then we have to evaluate physical examination. Okay, how is the respiratory rate? How is the heart rate? How is the BP? How is the oxygen level? Is there any axillary muscle working or not? So these are the basic things what we should see in the ICU or when the patient come in emergency with such a complaint. And next come the 2-3 important parameters. First one is the basic chest X-ray. So chest X-ray, as I told previously in my slides also, chest X-rays showed always in these cases of ARDS bilateral opacities. But with chest X-ray, sometimes it becomes difficult that it is either it is a heart failure or effusion, or there is atelectasis or not. So there is a role of USGs. But USG, the problem is you need a good operator or hands-on experience on USG. So in a big hospitals, it is readily available. But in cases of small resource-limited setting, it's quite difficult to find that kind of operator actually who can who has the expertise to do the lung USG actually. So if you have to rule out the effusion things and atelectasis part, because if sometimes it is effusion, so if you give some diuretics or significant in drainage in cases of significant effusion, so this may not be a true ARDS, that is a pseudo ARDS that improve eventually within a few hours. Okay, so next part comes the CT. So with the CT, we can identify the exact type or the pattern or the involvement in the lung. Is it a GGO? What we can see, there is two type. You can see that is a type L category of ARDS and type H category of ARDS. Type H, what we normally see, that is the bilateral basal large consolidations, and type L category, that is mostly comes from the viral pneumonia, what we have seen in the times of COVID actually, the extensive GGO involving the both lung parenchyma. So that was the most commonly pattern seen in the CT in cases of the viral ARDS. Next come the ABG. ABG is also important in terms of Berlin definition, so that we can quantify it, so we can put the patient in which category. Is it a mild category? Is it a moderate category? Or is it a severe category? And according to that, we can set our management. Is it we go for non-invasive or HFNO, or in cases of moderate, we directly go to ventilation kind of thing. And apart from that, we need some additional tests to rule out the causes, like in cases of pneumonia or sepsis, we have to identify the source of the infection. So we have to set the appropriate cultures, we have to send the appropriate biomarkers like CRP, procalcitonin, and we have to also do a echo routinely in cases of ARDS patient to look for any associated cardiac dysfunction, especially in cases of follow-up. When following up the patient in the ICU, there is a chance of developing right heart dysfunction. Even in our ICU, we sometimes do a diaphragmatic ECG to see how the diaphragm is working or not. So with this kind of things, apart from that, the fluid therapy part also. So with this kind of, we will gradually initially evaluate and then monitor the patient in our ICUs.
Yeah, so, very nicely covered, Arnab, because evaluation really helps you to reach a diagnosis and plan exactly what is going to be your management strategies as far as everything. The evaluation also takes into consideration the hemodynamics, because accordingly, what kind of fluids needs to be given, how fluids needs to be given, how they need to be optimized, everything can be planned along with the specific ventilatory strategies, which we'll be discussing in due course. This patient we initiated on high flow with about 60 liters of minute of flow. He was otherwise awake prone. He was not cooperative for the same. He continued to be tachypnic and a saturation of about 80 on HFNO. The ABG showed a PO2 of 66, PF ratio of course, less than 100, suggestive of severe lung injury. pH was 7.4, lactates were 1.8, and he was intubated and mechanically ventilated for worsening up of respiratory failure. He was put on volume control with 502 of 1, tidal volume of 300 cc's, a PEEP of 10. He was started on prone ventilation. ABG after 2 hours of proning, we got a PO2 of from 60 to 120 on 100%. Of course, the ratio was still just increased from 89 to 120. Then the lactates were 2.6. He was kept in prone for 18 hours. FiO2 requirement came up to 50 with a PEEP of 8. He was stable hemodynamically and was put on enteral nutrition support. He received 2 sessions of prone with average about 16 to 18 hours because it's sometimes very difficult to continue with beyond. And whenever we used to flip him again, he used to have his blood pressures or saturations dropping. So there was again an increase in the FiO2. There was increase in the PEEP requirement. We tried to maintain the peak pressures and also the driving pressure to about 12 centimeters of water. So the question, let's start off with Dr. Nilanjan. What do you think, which is the category of patients that you should consider to put them onto NIV and high flow nasal oxygen? Dr. Nilanjan.
Good evening, everyone.
Yeah.
So the role of NIV and HFNO in ARDS is unfortunately limited to only mild ARDS. That is when we have a PF ratio between 200 and 300. It's all the more it has become relevant because of the concept of SILI, that is self-inflicted lung injury,
right.
Which has been a distinct entity nowadays. So what happens in self-inflicted lung injury is that due to spontaneous breathing, patients of ARDS, they are having a very high respiratory drive and they are having a very high respiratory rate. So because of this, there is closing and opening of the alveoli, which takes place at a very fast rate, and this causes more diffuse alveolar damage. So there's been recent papers which shows that prolonged time on NIV for a patient with moderate or severe ARDS can actually cause more harm than good. It can lead to more diffuse alveolar damage. And even the lung safe trial, which has been done in 2017, shows that there is an increase in mortality when we use NIV for prolonged periods in patients of moderate or severe ARDS. So definitely early ventilation, early invasive ventilation for patients with moderate and severe ARDS. And regarding HFNO, which has been widely used nowadays, especially after the COVID pandemic, we can use the ROX index, which is a reliable indicator. Based on the ROX index, we can differentiate whether to intubate the patient or to continue on HFN. So the cutoff is 4.8, and I think if the ROX index is more than 4.8, we can safely continue with the HFNO. And if it is less than 2.3, then definitely we'll have to intubate. So early intubation, I think a low threshold for intubation is the key to ARDS management.
Yeah, I would slightly expand, along with this log indices, a clinical assessment of the patient is equally important, my friends. Don't just this, what he said is absolutely right, the ROS index and other clinic, but always remember that in case if the patient shows extreme tachypnea with signs of fatigue, alanasa, sternocleidomastoid, indrawing of the intercostal muscles, sweating, which can be seen on the forehead, and extreme exhaustion, definitely you should only think of intubation. That's very important. That's what exactly I'm going to ask Neel to talk. What is your experience, early versus late, and what has been your experience about this, about intubation? So Neel?
Sir, what I would think is that number one, like you said, clinical assessment. So especially we have to see the host, number one, whether, especially when we talk about lung disease. As an example, if a patient has a chronic end-stage lung disease, then in that case, the patient before the entire episode happened. If there's a malignancy patient, again, same story. We have to see the functionality just prior to the event, what exactly happened. Then what is the likely etiology and duration? If this is a primary insult or the patient has been in a hospital for around 10-15 days, is this a secondary sepsis? what are the current blood gas parameters, PF ratios, Apache scores, again simplified Apache score, SAPS2 has been, again, it has been validated and it has been studied for identifying categoric patients where NIV can still help more. But again, like I said, there is no one, like Dr. Subhal Dixit sir has said, that there is no one parameter. We need to use a variety of parameters. As we have said, lung safe trial has shown negative, but it was in 2017. After that, Florali trial has also been negative. But still, in the last 2 years, if we see the etiology also, COVID ARDS, non-COVID ARDS. COVID ARDS में दो morphology की, one was only ground glassing, one is aggressive, fibrotic, rapidly progressive disease. So in both cases, the PEEP response, steroid response is different. So we found there were so many hypoxic patients who were given awake prone ventilation with oxygen, with HFNC, and did have a good response where we could prevent intubation. We need stronger data from these last 2-3 years where all this is assimilated and we know that this is one category where patient might be prevented from invasive ventilation. However, an NIV trial, if at all is given in an ARDS patient, should be maximum for 2 to 6 hours. We should see the response. The patient does not, serial ABGs do not show improvement, persistent tachypnea, drop in GCS, worsening parameters overall, hypotension, need of inotropes, acidosis. These are all, so in conjunction with the clinical parameters, lab parameters, as well as the primary host and etiology of disease, we should take a call whether to, but most likely invasive is more studied. Invasive is more robust when it comes to data where ARDS is likely to respond, but still we should take into account all of these parameters before we take a call on early versus late intubation.
Absolutely, very nicely put up, Neel. Dr. Vikas, I would just request you to talk about the various modes. There have been plenty of modes. People do get confused whether we should use volume, pressure, when to use inverse ratio, APRV, PRVC, and more than this, the confusion which is being more and more complicated by the different ventilatory companies to label them as different modes. So which do you think is the ideal mode in patients of ARDS?
So I think the backbone of the ventilation remains the same ARMA trial, which focuses on the lung protective ventilation. So target volume has to be less than 6 ml per kg, as Dr. Neel has clearly mentioned, and plateau pressure should not be more than 30. So the most common modes used in ARDS, whether it's COVID or non-COVID, has been the volume control or the pressure control. Sometimes it's difficult to manage these patients on these modes, but yes, we have to make sure the patient is properly sedated and paralyzed if it's not being ventilated properly before switching on to some other mode of ventilation. So volume control, pressure control, they are the mainstay of the modes which are there. Now, third is your inverse ratio ventilation. In this, normally we set I ratio of 1:2, 1:3, 1:4, depending on the ABG parameters and the clinical parameters. Sometimes, if the patient is not being oxygenated well, this is a rescue mode. So not all the people are well versed with modes. I think the best strategy is choose the mode which you best know, rather than playing with the ventilator and different modes. If you're not well versed with APRV, PRVC, IRV, don't use it, because you will do more harm to the patient rather than doing benefit. So IRV is used as a rescue mode. It helps to improve the oxygenation, by increasing the mean airway pressures in the system. Next is your APRV, that is airway pressure release ventilation. Here, we set a pressure and the ventilator, in a time cycle manner decreases the pressure gradually from the higher pressure to lower pressure. So this is also used where the conventional modes are not very helpful. Then PRVC is a pressure rated volume control ventilation. It tends to achieve the volume at the lowest possible airway pressures, and this is also called as adaptive pressure control ventilation. So I think the idea is to use a mode which is best suited for you, or which you know the best, and it has to be in consensus with the lung protective ventilation.
Absolutely. Well said, Vikas. The best mode is what you are well versed with. It's like driving a car when you know how to do maneuvering and take care of the troubleshooting in that car. That's most important. And mind you, the entire concepts of management of ARDS has changed. Initially, everybody of us were ventilating for normalization of gases. And now what Vikas said, we don't ventilate for normalization of gases. We ventilate to see that the patient is being ventilated into a safety zone, maintaining the peak pressure, the plateau pressure, and the higher aspects of it is the driving pressure. So one of the aspects of that is, again, setting up of the PEEP to improve oxygenation in that. There have been different concepts and thoughts which have come up for PEEP setting, which Amato started off from the lower inflection point, taking into consideration graphics, till the time where we have got a ready-made graph which was available in the Berlin definition. There have been different thoughts which have come up. So I request Viswesvaran to throw light about how to set PEEP and what is the best optimal PEEP which he thinks is right enough scientifically. So Viswesvaran.
So if we speak about PEEP and the best optimal PEEP, the answer is nobody knows what is the best optimal PEEP, but there are many methodologies of the PEEP which are advocated for the patient. So generally we used to follow this FiO2 PEEP table which has been given by the ARDS net trial. So that has been the most common, and we have two types of PEEP table. One is a low PEEP table and as well as the high PEEP table, and generally we tend to prefer the high PEEP table. This is what we routinely do. But apart from that, we have got multiple modalities of setting the PEEP, and each one has a concept behind it. So the main things that have been tried in the past are something called as a recruitment maneuvers. So what they do is they keep increasing the PEEP as a staircase model, or what they do is they use a sustained high inflation pressure. That means they keep the PEEP at 30 for some time and gradually bring down the PEEP. But both of these recruitment maneuvers have found to be not so effective. The most common and found to be effective method of setting up the PEEP is to look into the transpulmonary pressure. But unfortunately, in most of the settings, we will not be able to measure the transpulmonary pressure. So that is more of a theoretical aspect. Now the concept is when you increase the PEEP and if you find that the driving pressure is decreasing, so that means you are in the right direction. That means like if the driving pressure is nothing but the P flat minus PEEP. So if you are increasing the PEEP and if you find that the driving pressure decreases, that means probably the lung is more recruitable. So that is another way of looking at how the PEEP has to be set. And apart from that, when we were doing a DM in Safdarjung, we had an access to even electrical impedance tomography. So this is nothing but a machine which is then applied to the chest, which shows the color codes like which portion of the lung is aerated and which portion of the lung is not aerated. And you keep increasing the PEEP so that you get a homogeneous distribution of ventilation. So that has also been tried. And people have tried to do the PEEP and immediately get a CT scan to see whether the lung has got recruited or not. So there are so many varieties of methods of setting up the PEEP. But I feel in the current time, the best two things which can be stick to is one, you choose a high PEEP FiO2 table. So that makes a rational for recruitment. The second thing is you always look into the driving pressure. So you increase your PEEP, and if you see that the P flat minus PEEP pressure falls, that means probably you are in the right direction. The moment you increase the PEEP, both P flat and the PEEP increases and the driving pressure increases further. That means your PEEP may be causing overstretching of the alveoli and it's capable of causing a barotrauma or a biotrauma. And the last method of is you measure the PaO2 and EtCO2 and the difference to look for dead space ventilation. As you keep over distending the alveoli, then there is a chance of dead space ventilation so that the PaO2 and EtCO2 difference may increase as well. But for practical purpose, either choose a high PEEP FiO2 model where we choose somewhere between around 10 to 14, or you choose the driving pressure model where you keep increasing the PEEP so that the driving pressure falls rather than increasing.
Yeah, so very well said, Viswesvaran. So mind you, it is not exactly, there is no exact figure. This for so much amount of PF ratio you apply, this is the PEEP it will open up. You need to juggle it up. You need to monitor the driving pressures, peak pressures, see that the delivery of tidal volume also occurs properly, see that you ventilate the patient into a safety zone. And of course, recruitment, which he's already covered it. So I would skip this question because they have not much done anyway. There were recruitments which were done of 25 PEEP for 25 seconds, or certain ventilator could have a 6-second cutoff where you could have the inspiratory pause, which could have been done. But the current papers which have done, they have not shown beneficial effects. And prone itself is one of the aspects of recruitment maneuvers. So I'll take this question to both ways. Nilanjan, can you tell how is actually a prone position done and how does it benefit? What are the benefits of prone? can you take this question, and then I'll move on to Arnab to take over another question about duration of prone.
Yeah, sure. So prone position, as we know, the well-known Proseva trial, it has demonstrated a strong mortality benefit for prone position, and the duration of proning that they have told is 16 to 18 hours. And the benefits of prone position, there are so many benefits. First of all, it reduces the VQ mismatch, and it reduces the weight of the heart on the lungs. It helps in better aeration of the posterior part of the lungs. So, and all this, now if you ask me how many sessions of proning done, it entirely depends on how the patient is responding to the proning session. Usually the patients who are having more infiltrates in the posterior lobes or the posterior segments of the lung, they would be benefited more with the prone position. And there is no single digit as such, but on an average, I think 5 to 7 sessions of proning is what we usually do for 16 to 18 hours. And then we see there has to be a significant difference in the PF ratios, and for which we can tell that our patient has responded to proning. And I think that only if our patients respond to proning, should we continue further sessions of proning. Like in the first or the second prone session, if the patient's PF ratios have significantly improved compared to the supine position, then we should definitely continue proning maybe for 5 to 7 times. Also, the other important thing is the hemodynamics of the patient, because I would certainly not prefer to prone a patient who is hemodynamically unstable. So that is another aspect. Please ensure that the patient is hemodynamically stable, because prone positioning has its own problems.
Absolutely, which I'll ask Arnab to cover. Arnab, can you tell what precautions do you take? Of course, monitoring the hemodynamics, and what all do you look into the patient when the patient is in prone? And yes, regarding sessions, what Nilanjan has said, I remember Gattinoni speaking in one of his talks that if I have ARDS, I would tell my unit staff to keep me in prone as long as they can really afford to manage me in prone. That's the real answer for it. So, Arnab, can you tell how to take a care of a prone patient? What all do you look for and monitor? How we monitor?
Yes, sir. So to prone a patient, what we do actually, we put a arterial line, central line, definitely to monitor the hemodynamics of the patients, and we keep the patient on deep sedation along with neuromuscular blocking agents, and we have to check for the alarm settings also. So these are the first requisite, and after proning, the main important parameters, what we see that there is any improvement in oxygenation, the FiO2 requirement is decreasing or not, the PEEP requirement is decreasing or not. And regarding the sessions, how many prone sessions, there is no definite. Even in Proseva trial, they have told that they may continue up to 28 days, then they leave to the physician's discretion. So if we not do proning, what do we do? If we ventilate the patient, so if the oxygenation is maintaining, and if there is a decreasing PEEP and FiO2 requirement with proning, we should continue with proning, because ventilation or proning or recruitment, these are not any curative strategy for ARDS. This are all the maintenance strategy. So we have to maintain the patient, we have to maintain the oxygenation, we have to prevent the VLI, and with normal ventilation, if it is possible, we'll continue with that. Even if we need proning, it will continue with that. In view that the lung will improve in at all when the primary insult is going on. So this is the concept. And regarding another important part, what my nurses definitely told me, sir, how will feed the patient in proning. So what we sometimes in many nursing home, what they do, they prone the patient, and the patient is prone, and so we are not feeding them. But feeding is important. So what we do in our setup, we use continuous feeding pump nutrition, through which we maintain nutrition throughout. And this is another part. And last part is that even after proning, if we see the PF ratio is going down, the patient is not improving, then we call the ECMO team for the further aid. And another important part,
we'll take it, Arnab, in the due course for refractory.
Okay. And another important part, we monitor the hemodynamic stability in that patient, because if the patient become hemodynamically unstable during proning session, we usually don't continue proning in those patients.
Yeah. So I'll just add further, friends, remember, once you put the patient on prone, see that you have secured the endotracheal tube properly. See that you have secured the central line properly or the arterial line properly, because you need to take frequent samples. See that you have properly padded the neck and the head end supported, the chest supported, the various pressure points supported with the help of air beds or with the help of nimbus beds or the pressure changes bed. Of course, you give a DVT prophylaxis. See that the tubes are secured, because that's a very high accident prone zone where the central line or the trachea or the tube may get dislodged. Always check for the cuff pressure monitoring into these situations. Use prokinetics, and I now said, yes, nutrition is important, don't compromise. Use prokinetics to feed these patients either with the help of feeding tubes. These are very, very important aspects, along with monitoring the hemodynamics. So I remember, go back to Neel now. The prone concept of awake prone came back. Way back, I've been in Pune ISCCM for long back, and almost a decade ago, while taking a NIV session, one of the gentlemen had asked me, sir, why can't we keep the patient in prone position on NIV? And that time it was honestly a big laughter that when that question was asked. But decades now, in 2020, after COVID came up, that question really turned up to be a reality. And can you throw some light on this, Neel, about awake prone? And do you really consider it to be done even now in COVID, in non-COVID ARDS?
Definitely, sir. In specifically, even non-COVID in viral ARDS or in etiologies where we know that the primary cause is the inflammation, which is going to cause more problems, where there is significant ground glassing, where, like you mentioned, Dr. Gattinoni, who had in fact given us different morphologies even during COVID ARDS, where there are some which are likely, which will benefit with awake proning. So in such morphological patterns where we see that there is likelihood that the patient is not very tachypnic, he remains hypoxic, needs oxygen, but does not require a very high PEEP, or the lungs are not very stiff yet. In such cases, there is likelihood that awake proning may still benefit the patients, but we have to take a decision based on the response to the treatment. One point regarding, just because we had, I think, a discussion regarding hemodynamic instability. So in cases of even awake proning, or even in cases of patients on invasive ventilation, on prone ventilation, if the patient is having hemodynamic instability, a lot of times low dose noradrenaline, some inotropes are going on. But when we use prone ventilation for invasive ventilation, it is a salvage strategy. So definitely it is a relative contraindication. But irrespective, the patient remains hypoxic, then even with the inotropes, a lot of times, based on, again, case-to-case scenarios, we may have to, for the oxygenation, we may have to prone the patient and see. And a lot of times the plateau pressure and the PEEP also come down, which actually also cause worsening of the hemodynamic instability, which may still improve if the PEEP requirement or the plateau pressures go down. So just hemodynamic instability or a minor low requirement of inotropes that's the clinical practice. What I'm not saying specifically, guidelines do mention hemodynamic instability as a contraindication, but it's a relative one. With respect to individual case, we can take a call.
Absolutely. Very well said, Neel. So remember, friends, that awake prone does help in early or in mild patients, which is there and which is now a reality, and you should really practice it, and everybody are quite well versed. So I'll take the case further, that this patient was prone from 9 a.m. for the next 2 hours. The FiO2 came to about 40%, PEEP of 6. And after 6 hours of proning, the patient started having tachycardia, hypoxia. So then he became tachypnic. He had drop in blood pressure, FiO2 of 1. The PEEP was increased to 12. The lungs were clinically clear. And mind you, remember, clinically, because of the PEEP effect, the lungs will be clear on machine that he was. The heart sounds were normal, although his extremities were cold because he was in shock with a BP of 86 systolic and a pH of 7.28, PO2 of 66, and a PCO2 which was gradually rising. So in this patient who was now being ventilated, prone, I would just take 2 or 3 other questions. One, Viswesvaran, can you talk about which patients would you like to do a early trachea And which way of trachea? Would you like to do a surgical or a percute? And when would
So regarding early tracheostomy, so anything which we do by around 7 days, generally we refer to as early tracheostomy. The dictum is generally we wait for 10 days and then we routinely perform a tracheostomy. And when we go beyond 14 days of invasive mechanical ventilation, we call it as a late tracheostomy. So generally, if in 4th or 5th day, if I feel like the patient is going to have a severe form of ARDS which is not responding, and if I anticipate that there could be a possibility of a prolonged mechanical ventilation, then I will definitely start the discussion about early tracheostomy to the patient by 4th or 5th day. Because that is the time we need to initiate this discussion, because the advantages of tracheostomy are many. Though in guidelines, it did not bring about a significant change in the ventilator-associated events, even if you do an early tracheostomy. But in a country like India, where the auxiliary healthcare system is not that developed, I feel like tracheostomy will help in maintaining a better oral sepsis and will help in better prevention of aspiration of the oral contents, and will also help about bringing down the requirements of the sedatives and the paralytics, because the patient starts feeling more comfortable, and it also helps.
Again, plus the dead space also goes down.
Yeah,
that also helps.
So the FiO2 requirement also grossly comes down. So any patient on 4th or 5th day, if the anticipation is for a longer duration of invasive mechanical ventilation, I would prefer a early tracheostomy. And but if I feel that the ARDS component is partly contributed by the pulmonary edema, and if I feel like it is showing a rapid resolution because of the pulmonary edema component, which initially contributed to the gross derangement in the oxygenation, then probably these are the patients who may come out very fast. And once the PF ratio improves more than 150, I may even go for an early extubation and put them on an NIV, provided I feel like the pulmonary edema component has contributed more to the ARDS than the ARDS per se itself for the failing oxygenation.
Yeah. And when you're extubating, when you always remember, friends, that there has to be a safety zone that at least the FiO2 should come down to 50 and the PEEP should also come down to about 7, 6, 7, 8. So that's the way we can easily deliver it by a non-invasive way. That's the time you think about it.
And another part of your question, whether it is a percutaneous or a surgical. So these days, there has been an increase in the interest of percutaneous tracheostomy. But the point to be noted is, if you see that the number of the incidents of post-intubation and post-tracheostomy, tracheal stenosis coming secondary to a percutaneous tracheostomy by a not so qualified person is very, very high. So even though it looks very attractive to do a percutaneous tracheostomy, until and unless you are using either a bronchoscopic guidance to exactly see that you are not causing a injury, or there are also high risk of causing a posterior tracheal rent if you don't use a guidance. So I feel like though the interest has been more for a percutaneous tracheostomy, especially amongst the intensivists, what we have observed of late is there is an increase in incidence of post-tracheostomy tracheal stenosis because of the blunt pressure with which the trocar is passed, and later once they decannulated, there is an infolding of the tracheal cartilage, which is causing a high incidence of a post-tracheostomy tracheal stenosis.
Yeah, I agree with that, and you should do it more of with a bronchoscopy or with ultrasound guidance.
Yes, that should be mentioned.
Yeah, that's
so. But in general, if there is a trained team, I would also prefer a percutaneous tracheostomy. And the indications for a surgical tracheostomy would be like if the patient is going to have a gross hemodynamic compromise, I don't want to take any chance with respect to the airway. And second thing, if the PEEP requirements are going to be very high and the FiO2 requirement is going to be very high, then probably while doing a percutaneous tracheostomy, there is going to be a loss of PEEP to a greater extent. So I wouldn't advise doing a percutaneous tracheostomy. And the third thing is, if you have a very short neck and an obese person, where defining the anatomical landmarks becomes a little challenging.
Short neck has to be a surgical, especially if you have a good anatomy. You can easily think of a quick in, quick out. As you said, if it's a trained, experienced person to think about a percute, probably is doing it under ultrasound guidance.
Yeah. And any bleeding diathesis will become a
that always has to be taken as a part of protocol. Arnab, can you just quickly go into the steroids aspect of ARDS? There have been every discussion about it. It's like a rapid fire question. There have been a 6 versus 12 milligram. There have been Dexa. There's been methylprednisolone. In COVID, everybody has used left, right, center, whatever doses they want. But let's go into science and reach a conclusion as to is steroids a yes or no in ARDS?
Definitely, I'm very steroid pro person. And if ARDS is an inflammatory condition and steroid is anti-inflammatory, it should work. And even we have seen in recovery trial 2021 in COVID ARDS, it has improved the mortality a lot. Even in 2017, in a guideline, sepsis guideline, it was mentioned for methylprednisolone also. The important part is the type of steroid, the dosing of steroid, the timing of steroid, and the duration of steroid. Typing, Solumet, methylprednisolone, dexamethasone, all are equivalent except for the mineralocorticoid activity. The separate steroids have not shown any improved mortality over one another. And regarding the dosing, if we go by the Dr. Villard study in 2017, I think DEXA ARDS trial, so they have used 20 mg of DEXA initially for 5 days and then 10 mg for another 5 days. So this was the dose they have studied, and they have showed the improved mortality. And this was a non-COVID ARDS trial. So that has been shown benefit in this trial. And regarding the timing, we can give early, we can give late, but more early if the patient is not improved within first 24 to 48 or maximum 72 hours, we may start steroid in these patients and see the recovery, there is increasing recovery or not. And the duration, they have shown that it has to be given at least for 10 days, at least more than 7 days. Otherwise, there may be rebound injury in these cases.
Yes, thank you, Arnab. So let's be short on this. So nutrition is one aspect is there. We know that enteral nutrition support needs to be given. Early enteral nutrition support needs to be given under the role of under the role of pre-probiotics and prokinetics you should feed. I just want to ask a very specific question. There was a fish oil which was used as an anti-inflammatory action in COVID ARDS, which are also included way back into the ESICM guidelines. So Vikas, can you just throw some light on the role of immunonutrition in septic ARDS? Is it still on or is it off label now?
Well, a lot of immunomodulation nutrition has been suggested and tried in various patients of ARDS and other clinical care settings. Antioxidants, omega-3 fatty acids have been tried. But, the recommendation is to use the nutritional dose of omega-3 fatty acids. High doses of omega-3 fatty acids, DHAs, has shown to harm the patients rather than doing benefits. So a cutoff of 500 milligram per day has been suggested. That is the nutritional dose of omega-3 fatty acids, which have been shown, though the recommendation is not very high, but still can be used. Apart from that, vitamin C, vitamin E, and azithromycin as a immunomodulator agent has also been used.
Yeah, but mind you, when you are using immunonutrition in patients of ARDS, whether it's septic, mind you, keep in mind that one, the patient should not be into septic shock. That's one. Yeah. Secondly, they should not be having into renal failure or renal dysfunction. These are the two prerequisites when you can consider to use it. And more importantly, the whole if it's mainly associated with a traumatic brain injury or with trauma or in patients of burns, these are the indications where you can have consider to use it. Otherwise, it's a big no, as what Vikas said, and now it's practically out, excepting for omega-3 in short doses as an adjuvant form of therapy. So rescue therapy, I would just go into it. How many of you, it's a quick rapid fire for all the panels. Do you use nitric oxide to manage refractory ARDS? Let's start off with Neel, Vikas. Quick yes or no? It's like a rapid fire.
No, sir, we have not been using nitric oxide at all.
Yeah.
Neither prostacyclines.
Arnab?
No, sir.
No role?
I have not used it, sir.
Okay. Neel?
Not used, sir.
Yeah. Viswesvaran?
No, sir. We don't use it.
Yeah. And any role of any aviptidil, which is now being promoted for in patients of ARDS. Does any panel have the experience of using it? Aviptidil. I have no experience of using it. They have said that you can use it like anti-inflammatory or like an immunomodulator, same principle like all the immunomodulation way. I have no experience, but provided the patient does not have any cardiac dysfunction. This was what is being told to me. So I would like to have the expert panel opinion here on aviptidil.
So we have not used it, but on papers, it looks like a good drug. It stimulates type 2 pneumocytes, which, decreases the inflammatory response, and definitely, the surfactant also improves. So clinically, I have not used it. I have just read it in the papers, and it looks promising on the paper at least.
So no, there is no the RCT. Good quality RCTs are there actually. And if you see the papers, most of the papers come from a single author. Okay, you just look for it. Yes, I am not commenting on it, but it comes from a single author. Okay, but I have an experience with ECOR. I can share a view for ECOR.
So I was just coming to that. ECOR and ECMO. I would like to know your thoughts, because we use it, friends, for rescue. Fine, mind you, I would like to still say, as the most important, always manage your patients. Don't compromise the basics of intensive care. Always take care of the fast hug and the BID approach. See that the patient's all care is taken. See that you continue to ventilate the patients on the mode in which you are comfortable, monitoring the peak pressures, plateau pressures, driving pressures. Continue to keep them in prone as much as possible. Even if you don't have the high-end monitoring techniques of transpulmonary pressure, transesophageal pressures, mind you, patient's life can still be saved. In case if it's a refractory, ECOR and ECMO is one of the way. And I would like the panel to throw light onto it. Which patients would you select?
Sir, in case of ECOR, isolated ECOR, because in cases of ARDS, the normal thing is the primary endpoint is to maintain the oxygenation and to prevent ventilator-induced lung injury. So isolated ECOR we are using in patients who have in which patients we are using ultra-low tidal volume study. That is a 3 to 4 ml per kg tidal volume in extensively involved lung parenchyma. So in this patient, if we can maintain the oxygenation with the 3 to 4 ml per kg, but there is gross CO2 retention in these patients. So with this ultra-low tidal volume strategy, we are using ECOR simultaneously to take care part of the CO2.
Right.
And yes.
And ECMO, which would you like to do? Would you like to do a AV or VV ECMO?
So initially we start with VV ECMO, and sometimes we have to convert it to, depending on the situation, VA, if there is any cardiac compromise. Sometimes we use VAG ECMO. But definitely in our center, we are using a lot of ECMO. Even in COVID time, we have used almost 30-35 ECMO at a time. In cases of severe severe ARDS patients. But ECMO definitely has good outcome, not in terms of COVID-19, because in COVID-19 the situation, the scenarios are quite different. But if you choose early, if the timing is important, if the timing is appropriate, ECMO has wonderful outcome.
Right. So mind you, I would still stress point, those hospitals who do not have ECMO, those units do not have ECMO, don't be disheartened, because the basics of intensive care is maintaining and ventilating into the safety zone. Yes, you can have a rescue therapy. It's one of the rescue, because hardly 10% of these patients or 20% may need ECMO. Other 70-80% do come out without ECMO with good ventilation. That's the most important thing. So I'll move further. The patient had tachycardia. He had a pro-BNP which was 1240. Tropi turned out to be positive. In due course, his PEEP requirements and oxygenation requirements did go up. We did get an echo where we saw a dilated amount of ventricles, which was seen here with a borderline amount of ejection fraction, which was there. So he was put on non-epinephrine, put in supine, antimicrobials were changed from typical to meropenem, ticoplanin, LMWH was given, and continued on supine position. So I would like to ask you, a new onset of shock, how will you distinguish it into ARDS and non-ARDS? So Vikas and Neel, you can take the questions and give your thoughts, opinion on this. A shock in ARDS, in short, how will you handle it?
So basically, we need to look what is the reason for the shock, whether it's a septic shock, whether it's a cardiac shock, because a lot of cases, pulmonary embolism is no entity in ARDS. And otherwise, in other clinical settings with a non-ARDS type of setting, sepsis is the main component. So we look at the various parameters worsening. Initially, if the patient is improving and suddenly, hemodynamics go haywire, saturation keeps on going down, or, the TLC count is going up, patient is going to new hypertension is developed. So we need to think about shock. So one important aspect is, getting a quick bedside ultrasound, echo of the patient. That will help us to distinguish between, at least between if there's severe pulmonary embolism, RARV is dilated, then probably we are looking at massive pulmonary embolism rather than septic shock. On the other aspect of, global dysfunction is there, toxic myocarditis is there, apart from increasing hypertension, probably sepsis has to be looked into that. And maybe we need to upscale our antibiotic, CRP or PCP has to be repeated and see the.
Yeah, absolutely right. So mind you, equal hemodynamic monitoring with echo, with ultrasound plays a very important role. And you should have an overall perspective, take care of the patient as a whole. Look for PE, look for the cardiac dysfunction, because that will also help you to optimize the fluids properly. Arnab, just throw light about the role of multiplex PCRs, these polyplex PCRs, rapid molecular diagnostic techniques in the diagnosis of ARDS.
Sir, yeah, it's hard. It looks fascinating to hear this kind of terminologies, but it always clinical. So if the patient in ARDS, and if you see the changes in plateau pressure, changes in the respiratory secretion pattern, and changes in the hemodynamic, that is the first thing when we think of that something new is going on, the sepsis is going on. And regarding the multiplex PCR part, what you are telling about, see if we say what we in our setting, what we practice is if we see send it, we'll send it on the initial during admission part, because after 48 hours the respiratory tract is colonized with so many bacteria and kind of thing. And if we send multiplex PCR thereafter, many bacteria comes with many types of resistant pattern, and it is very difficult to identify which of these bacteria actually causing the infection. So important is the culture and a thing. And regarding the CRP, procalcitonin part, definitely serial monitoring is important. Not a single value is of much value. In cases of fungal, we can use galactomannan or beta-glucan. And nowadays we are also using IL-6. We are using to prognosticate the patient, and we can use sometimes cytosol therapy kind of things depending on its value.
Absolutely, very well said. So this patient.
So just one point here that with this, when we talk about shock as well as the biomarkers both, besides the primary etiology, we also see what we are doing. Like, is it causing any of these changes? Like, as an example, if the hypotension is worsening, we are putting the patient on noradrenaline, but is the plateau pressure high? Is the PEEP high that is causing this? Second, biomarkers like Dr. Arnab mentioned, galactomannan. So there are antibiotics which cause high galactomannan. So is it any etiology in amongst the treatment that we are offering, or any drugs we are giving? Again, with regard to abitpredolol, we had that discussion. So the mechanism, it binds to the ACE2 receptors like SARS-CoV and blocks the action where COVID does not act. So again, there have been other drugs like ibuprofen, which was shown to be protective. But is it any treatment related, antibiotics, ventilation, where that is causing an abnormality in the reports beside the primary etiology of septic or cardiogenic shock that we are suspecting? That we should also rule out.
Yeah. I would just take Viswesvaran to throw light exactly. How would you like to keep the fluid management? Be short, we have got last 5 minutes to go. Fluid management and resuscitation in these ARDS patients. How would you like to keep them dry, euvolumic, or how?
So it's a conservative strategy. So keep the lungs as dry as possible, because of capillary permeability. Whatever fluid we give is going to decrease the lung compliance. Right. And second thing is the general fluid, which nowadays has been advocated by the sepsis guidelines, is more of ringer lactate rather than the normal saline, because normal saline at high volumes causes metabolic acidosis and even causes acute kidney injury. So if you have an access to ringer lactate, it's a better alternative.
Or even use balanced crystalloids.
Balanced, like plasma light and
balanced crystalloids do play a role. We have to cover about the. So mind you should keep the patients euvolumic and dry. The drier is better side. Of course, monitor the hemodynamics. Now with the help of ultrasound, you can look for the IVC collapsibility, monitor the urine output. You can monitor the LV function. All these play a very important role as far as the hemodynamic parameters are concerned. As far as one extracorporeal should be started, we did discuss. It is mainly into a refractory kind of ARDS. So selection after, once you have stabilized the patients, optimize the entire normal protocol of ARDS for ventilation. In case if you still find that's very difficult to get down on the PEEP requirements, FiO2 requirements, then you should consider to use it as a part of the treatment. Of course, hemodynamic monitoring is equally important with the help of arterial line. And of course, if the patient is in shock, we use a standard protocol of noradrenaline. And in case if the LV function is compromised, monitoring the echo as far as dobutamine is concerned. So I would here end the question answer session from the panel. I would like to take up certain questions which are there, a few common questions which are important from the chat box, and open it for the panel to take them. So can I have the questions from the chat box? So yes.
Dr. Subhash, I have to rush for emergency hospital.
Yeah, in fact, even I have got last 2 minutes because I've got another webinar on the Chinese society.
Yeah. So with the permission, can I just go to the hospital?
Yeah, you can leave. No problem.
Yeah, please. Thank you. Thanks a lot, Dr. Subhash.
Thank you.
Thank you, everyone. Thank you.
So I think we have seen that ARDS due to viral and other, there is not much amount of difference. Mind you, you can consider to use the rapid molecular diagnostic techniques early in case if the patient is affording to distinguish between viral or bacterial or fungal. Another question, which is there any special type of ventilator is in the pipeline for ARDS? No, there is no special type of ventilator which is there in the pipeline. Mind you, a good standard ventilator which has got all the basic modes and all monitoring techniques which play a very important role. Of course, a big no for the PM care ventilators. Mind you, I'm sorry to say, but I'm very blunt about it. But a good ventilator to have a good monitoring techniques where you can monitor the peak pressures, plateau pressures, driving pressures, and the basic compliance, resistance, graphics, though any machine where you are comfortable is very, very important. But please, a big no to putting patients onto a PM care machine for ARDS. It's a big no. That's what is there. What should be the peak pressures, ventilatory strategies? Arnab is definitely said, keep it simple. See that the peak pressures don't go beyond 35 to 38. The plateau pressures don't go between 25 to 28. The driving pressures doesn't go between above 15, keep it between 12 and 14. So mind you, the concepts of ventilation management has changed. Initially, as I said, we were ventilating for normalization of gases. Now we ventilate to see that the patient remains into a safety zone, monitoring the peak pressure, plateau pressure, driving pressure, so that we don't have lung injury. And the patients, now the lung injury is not a ventilatory associated lung injury. It is also a self-inflicted or a physician-induced lung injury because you and me are setting the machine. So we need to be aware about how to set the machine and how you should handle it and monitor it. So these are the certain questions which are there in the chat box. On behalf of CCI, I thank all the panelists to sharing their thoughts about the basic aspects of management of ARDS. And mind you, I would still stress the basics of intensive care, the basics of ventilation. Don't forget, ventilate the patients into a mode in which you are comfortable, monitoring the peak pressures, plateau pressures, driving pressures. Of course, the fast hug care, DVT prophylaxis, monitor the hemodynamics, take cultures, monitor the fluid status, monitoring the IVC collapsivity, keep the patients dry. These are the basics what you should see in order to save the life. These are my take-home messages. Just one quick take-home message from all the panelists before I hand it over to the CCI admin. Quick take-home message, Neel.
Sir, a quick take-home message. One would be lung protective ventilation is the way to go. We do not cause more harm, like you mentioned, primum non nocere, no harm that we should be doing while ventilating the patient. And the permissive hypercapnia and permissive hypoxia, both are important.
Just one-liner take-home messages. Arnab?
Yes, sir. We only not have to protect the lung, we have to protect the diaphragm also. This is the new concept which is coming in.
Absolutely, I agree with it. Viswesvar?
When ARDS is not improving, think about proning and ECMO.
Absolutely. That's a very important part. We should think of early proning, which plays a very, very important role. Yeah. So these are the thought processes. I thank CCI and I hand it over back to the chairman of the CCI to give these closing remarks and before we say a good night. So thank you very much, CCI, for inviting me to moderate this session. And thank you, panelists.
Thank you, sir.
Thank you, Subhal sir. Thank you.
Thank you, CCI.
Thank you.
Thank you, sir. Thank you.
So are there any closing remarks or we end here?
I think nobody is there from the.
Okay.
Okay, sir.
I think
So I think Neel, you can thank everybody on behalf of CCI or whosoever is the organizing committee person from CCI.
I think Dr. Neel would do that.
Yeah.
Okay, so thank you everybody who's joined us today for this webinar, and Dr. Subhal sir, thank you so much for moderating this session in such a great way and covering most of the practical aspects of ARDS management. And thank you all the respected panelists, Dr. Arnab, Dr. Nilanjan, Dr. Viswesvaran, Dr. Vikas, Sikri, everybody who's joined us today, and hope that we have had a good practical discussion into management of ARDS. Thank you, CCI. Thank you, the technical partners, Cipla, who helped in today's webcast. Thank you so much.
Thank you very much. Good night.
Good
See
night.
you. Bye-bye.